Now I've got it and I've got it recording. Perfect. All right, so today what we have, just a quick overview, is we already talked about what we're going to have for today. So here's your kind of agenda for the day, and this is going to be the same agenda that we're going to have for every single meeting, which will be that topic presentation and the case presentation that we talked about. Then we have a fancy little name for documentation autopsy, which will basically be kind of helping us dissect how the specific coding needs to be in order to make sure that it's actually accomplished. And then we'll have those number of clarifying questions and assessments that we can have in that kind of brief Q&A, and then those open-ended questions. And so now, with the second try, we'll have Zach and Andrew educate us on kind of the difference between medical billing and pharmacy billing.
Thank you, Renee. Let me see here. I'm trying to reshare what I was already. There we go. Can everybody see my slides?
Yes.
Perfect. All right. So today we're going to be talking a little bit about the differences between the medical benefit and the pharmacy benefit and how to broadly view those from a standpoint of practicing and from billing. So in general, when you think about like what type of benefit we're talking about, there really breaks down to two types of benefits at the managed care level. You have the medical benefit and you have the pharmacy benefit. And there may be other types of benefits that are implemented in there, like behavioral health or a DME benefit. And oftentimes there may be some type of crossover between those, particularly in the DME space. But in general, when you look at it from a managed care perspective, these are two very separate pots of money that are very insulated from each other. And under the medical benefit, what we're talking about is more of the outpatient physician services. We talk about hospital services, skilled nursing facility, DME, which we already talked about. And under the pharmacy benefit, we're talking more about what we typically as pharmacists think of. We have covered outpatient medications, dispensing services, Medicare Part D, MTM, care plan activities, which are becoming more popular. And those are the type of ways that these different benefits covered services for their members, and how you bill them is separately and distinctly different from each other. Even though they may share some similarities, the coding is often very different and doesn't transpose very well between the two. From a health plan perspective on what type of payer that you're going to be billing, you need to know that first and foremost before you actually drop the king. So there's generally three types of insurances. We have Medicare, we have commercial, and we have a state Medicaid insurance, and maybe an insurance exchange. On the Medicare side, we have Part D, or for the prescription drug plan, which it can be commercial. Usually it is these days, or it could be both commercial and the Part B side, or the medical side, which is called the Part C commercial plan. And a health plan that's made in a bid on the commercial market could provide both the Part D and the Part B, as well as some Part A services. But generally, Part A comes into a different benefit altogether when we're talking about Medicare. So from the pharmacy side, we're very familiar with Part D as pharmacists, as I'm sure, but we're probably a little bit less familiar with Part B. And the equivalent to that from the commercial side, which is the health plans that contract with Medicare and bid to Medicare to provide that services, are called Part C. Now, Part B Medicare, straight Medicare, those are your typical red, white, and blue cards, which we've probably gotten pretty familiar with the COVID pandemic and utilizing, paying for vaccines. Those are general Medicare or straight Medicare. They follow Medicare's rules to a T. They don't necessarily have to take into consideration state scope of practice laws like the Part C plans or the Advantage plans have to. And they also are run by regional MACs, or Medicare Administrative Corporations. And ours, being Meridian, is the regional MAC for this area that both Oregon, Idaho, and Alaska are run under. They all may have different policies specific to the regional MAC that differ between the two, but in general, they're following the Part D benefit coverage for Medicare to a T, whereas Part Cs have to cover that, but they also have the option of choosing additional things that they can cover and selecting additional providers who can administer the covered services for Medicare. Part A is going to be mostly your hospital, your skilled nursing facility, your hospice areas. There is very little coverage outside of that, and that's also usually included within an Advantage plan's Part C plan, but it doesn't always have to be. And of course, there's supplemental plans like that for Medicare, but we're not going to go into those too much. And then you have the commercial side. And commercial side, those are run by the state themselves. The state insurance bureau or the finance bureau or insurance division, consumer business bureau like it is in Oregon, they make the rules and regulations surrounding what commercial players have to cover, and they usually have a state-defined essential health benefit that forms the basis of all covered services within that state. They have a pharmacy benefit, just similar to Part D. They also have an outpatient medical benefit, and they may have some hospital or skilled nursing benefit, or you may have to get a supple benefit to be able to get access to those services for coverage. And on the state Medicaid side, we don't call those the pharmacy benefit often. Most of the time, they're called the pharmaceutical service category. Those types of benefits are written into the state Medicaid's rules or laws and how they're administered. They also have a medical side, usually termed the medical surgical side of the benefit. We'll list out what covered services are there. And they will have a separate section on hospital and facilities. And much like Medicare, which is defined and also applies to the commercial side under the essential health benefit, state Medicaid programs also have a baseline coverage status called the state plan amendment, which defines the types of services that are covered and federally matched dollar for dollar for the state. Now, the state can choose to cover additional services outside the state plan amendment that come out of the general funds, but often that's not the case. And they usually always want to get that federal matching dollars to be able to supplement the services they're providing to the people who are part of the Medicaid assistance program. This is just kind of breaking down in a table form the common and types of service and benefits that are covered under the prescription benefit or the pharmacy benefit. It's the prescriptions, immunizations, professional
Andrew
dispensing
dropped out.
fees. Oh, I'm sorry. How about now?
Can you guys hear Andrew?
I can hear him.
I can.
Julie, can you hear him?
I can. Yep.
Okay. Can you hear me now, Tom?
So
All right,
okay,
good.
perfect.
And there may be some more clinical services that are covered under the pharmacy benefit, like clozapine marketing or certain REMS programs, where a pharmacy can get like a professional fee or an incentive fee for providing those services. There's dummy NDC codes and DUR codes that can be used on the pharmacy benefit to bill for additional covered services outside the traditional dispensing throw. But all pharmacy benefits have some sort of administrative cost component to them that they have to incorporate in their bid. And those are for demonstration projects, for the administration of Part D medication therapy management. Yes, that's usually comes out of a health plan's administrative cost to get altogether and not really incorporated into their typical covered service benefit. And on the medical side, it's very similar. What you would expect. These are payment and provisions for the prevention and diagnosis and treatment of human disease or pain. These are your typical outpatient health services, inpatient services, institutional services, DME, mental health, behavioral health, like all of that we just went over. They also have to bid for their administrative costs and for their risk recapturing activity, which has to do largely about how you code an encounter under the medical benefit so that the health plan can recapture the risk of their population so they can adjust the cost of the population sufficiently. So in their next bid, it'll be adjusted so they can be paid more and in turn also pay their providers more based off the risk that they've recaptured. There's many other provisions in there in the administrative benefit on the medical side. It has to do with hiring nurses to do chart reviews to do that. But simply put, if you're really good at coding your services on the medical side, you can really help a medical benefit really recapture risk efficiently and significantly lower their administrative costs. This is just the general process for how a pharmacy is paid on the prescription benefit and comparing that to the medical reimbursement process, which is very similar, but also very different because we're providing a different service. We're providing a service outside the dispensing of a drug when we typically think about the medical side, but that could also mean that services could be provided in office too, in terms of brown bagging, or if the practice itself purchases the drug and administers it on site as an infusion. Even in some circumstances where a clinic may contract with a pharmacy to purchase or prepare the medication and have the patient bring it in the form of a white bag or a brown bagging type of situation. So there's a lot of crossover here. So it can get kind of confusing and gray. So it's really important from a provider standpoint, where is it, what are you doing right now and what benefit are you billing? It needs to be at the forefront of your brain so that it's done correctly. And that's the brief intro for the differences between the medical benefit and the pharmacy benefit. Is there any questions?
Actually,
This is,
oh, go ahead.
this is Julie. I just had one question. Is is this PowerPoint something that we can have emailed to us afterwards, do you think?
Yes, we will get that to you, Julie. And then we'll also have it posted on the website as well, along with
Oh,
the
okay.
video. So we'll have both of those. So this way you can share it with the other pharmacists at your site, because we also know that, you know, the pharmacists and technicians can't all, like, everybody can't close down the pharmacy for to be able to attend. So this way we'll have all of that stuff available to you.
Yeah, there's just some really handy charting in here. So I just thought it'd be good to have some of this. So thank you.
Hey, Andrew, this is Barry Christensen. I have one question regarding the difference or the pros and cons between physicians' offices, for example, when they purchase medicine, an injectable to be administered to a patient, versus pharmacy billing for the medicine and then administering separately via the major medical benefit. Can you like kind of discuss pros and cons, or if they're, or only if there's pros, that's okay too?
For Barry, I'm gonna see if Zach has any input on that from his clinic experience. Me build off of Zach.
You're calling out a great area that I was actually just hoping to highlight. So one of the things I would call out here is there is some overlap in what is covered under the medical benefit and the pharmacy benefit, and you called out a great example, and that is going to be administered pharmaceuticals. So a lot of times you actually have the option to bill an administered pharmaceutical under the pharmacy benefit and add an administration fee into that prescription claim, or you can bill it under the medical benefit, just like you're asking, as a provider administered drug. Typically what we see is with the medical benefit not being processed through a PBM, we oftentimes see contracts that reimburse provider level administration of prescriptions at a higher rate than we would receive if you administer it and bill it under the pharmacy benefit and add a medication administration fee into that. So generally speaking, you will see a larger reimbursement under the medical benefit for that drug based on the contract with the medical payer.
Okay.
So that's the positive. One of the caveats of that being, a lot of times there will be prior authorization requirements on the medical plan side before administration. And with another one of the differences between the two processes, the prescription reimbursement versus medical reimbursement, with, as you know, with the prescription, you get real-time rejection. So you are going to process that claim through before we actually fill the prescription for the patient or administer it to them. So they know what their copay is at that time. They know if it's covered or it needs a PA then. On the medical benefit side, if you haven't done your work to confirm their eligibility beforehand or confirm if that medical plan requires a PA for a physician administered or provider-based administration of a drug, you might get into a situation where you've administered the drug, a PA is then needed, and you either can't meet those criteria and end up having to eat the cost of it, or have to jump through hoops to get that paid for once you've already administered it. Because the medical reimbursement process is one where you will collect a copay if there is any, and generally render a service well before you know if the service is going to be covered, because after the service is rendered, after you document, after you submit the code, then there's this waiting game for waiting for the medical claim revenue cycle to pass and actually get adjudication maybe 60 to 90 days after you've performed the service. So that's the downside, is you may get into a situation where you either won't get paid or don't know if you're going to get paid when you're administering a drug.
Gotcha. Okay. Yeah, that's great. And as kind of a follow-up, and some of us have had a conversation about this, but in the pharmacy world, of course, the PBMs are keeping our feet to the fire in terms of like the copay collection and how we collect it and all that. And so on the major medical end, we have the same kind of requirement, correct? I mean, so if we bill for administration and they don't pay 100% of it, we're obligated to bill the patient for the remainder, correct?
Well, yes and no. It depends on their insurance type. So there are certain insurances where, actually, it's a bigger question than a simple answer. It depends on the insurance type. So whether they're Medicaid, Medicare, commercial, and it depends on your contracting and credentialing status with the payer. Some of the medical payers will have very similar rules where you either have to collect, they put it in their contract terms that you have to collect a certain amount of payment or the co-payment from the patient. There are different ways you can set up your fee schedule and your billing policies where, based on patient need, you could waive a copay, or you could have a self-pay fee schedule that's completely separate from your usual and customary. So there are, I think, more opportunities to provide patient assistance under the medical benefit than there are under the pharmacy benefit.
So maybe we could revisit that too over the next couple of weeks, and maybe collect some additional information on that of here are a couple examples and when we'd apply those. And that might be really helpful for us all to kind of think of in which cases would we do this or that.
And I'm going to jump in there and just add a couple more points on to Zach's. When you talk about pros and cons, Barry, some of the major pros, especially being an independent pharmacy owner, is when you look at the office-based administration or the medical side administration, there's not going to be any DIR fees or price concessions on the back end. The contract and the amount that's agreed upon from the health plan, you're dealing with a health plan here, not necessarily through an intermediary like a pharmacy benefit. So what you get paid for, what you submit and what you get paid for is going to match, and there's no clawback on the back end. So you're getting an upfront payment, but that payment may take anywhere from 30 to 90 days for you to actually receive or even get notification that it wasn't projected. So there's a risk there too, unless you know your contracts pretty well.
Okay, good to know. Thank you.
Awesome. All right. Well, now to kind of switch the way we're kind of approaching this, what we'd like to do is actually provide a case, an example. And so we'll have Jordan Bell actually provide an example from her clinic and then look to our experts for some guidance on how they would document and bill for those services, and what they would do and compare the two different ways to potentially bill for those services. And so Jordan, would you share with us kind of your clinical case that is pretty similar to what many of us have seen in a number of ways?
Yes, and is somebody going to share the case?
So you're able to share your case. I don't have your slides.
Okay.
But if you send me your slide, or because I did not get your slides, but I'll make sure you have 1 second. Here you go. I made you a co-host, so you can now share the slides.
Well, it did not send me a copy of it when I submitted it. So I have it pretty much. It's not going to be word for word what I sent, but I think I pretty much have what we're running through.
While you're while you're walking us through, we'll get Madison, we'll pull up your Qualtrics response thing and we'll post that, okay?
Perfect. All right, well, we'll go ahead and get running. So the patient that I'm going to be talking about today, of course, I need the age. He's a male in his 50s and he was referred for diabetes management at the outpatient clinic that I work at through our collaborative practice that we have with our providers here. And it was the initial diabetes visit with me while he has previously been seen before with his provider. So the reason for the referral was, like I said, in general, diabetes management after an A1C came back fairly elevated. So for this patient, significant past medical history, type 2 diabetes for 6 years with complications, hypertension, hyperlipidemia. Primary concerns, just after reviewing some of the previous notes from the provider over the last 2 years, was it seems to be there were kind of bouts of different varying times where the patient struggled with adherence. Typically, the reason was due to inability to afford medications based on insurance dropping, and elevated A1C pretty consistently for the last 2 years. I think the lowest had been like a 9.8, but typically over 10. And then also limited information for self-monitoring blood glucose. Patient does not like to test, was attempted to be placed on a CGM, a Freestyle Libre, and disliked it, which we don't hear a lot, but was not a fan and did not want to revisit it based on kind of reviewing the patient's history. So that's kind of all, kind of a general overview for when the patient was coming in. This is the information we had. So when the patient came in, the focus was on type 2 diabetes and that elevated A1C. And I want to say it's 12.4% since we're not looking straight at it. So fairly elevated. The blood glucose in clinic with the previous visit with the provider was in the 300s. Hey, there we go. All right, there we go. Okay, that was perfect timing too, because yeah, you can go down actually. Yeah, 12.4, perfect. So the current diabetes regimen that the patient was prescribed per the provider was, can you go up a little bit? There you go, right there. Okay, so as metformin max dose, Jardiance max dose, and then the patient was also on long-acting insulin, Levemir, 62 units nightly, which was about 0.56 units per kg. When the patient came into the visit, turns out the patient is now currently on Medicaid. So there was no issues getting the medications, and there was no issues currently with adherence. Like I said, the patient's most recent A1C was 12.4. The blood glucose in clinic was ordered that day since there was no home monitoring going on to kind of get a picture of, what's our day-to-day looking like. Fasting blood sugar was taken, it was 212. In terms of positive symptoms for hyperglycemia, the patient reports polyuria, which wakes him up overnight about 2 to 3 times. No symptoms of hypoglycemia based on kind of our discussion. However, the patient's also not monitoring, so we can't 100% confirm that, but likely not experiencing hypoglycemia. All right, can you go down a little bit, please? Thank you. So patient-oriented goals. This patient, relatively young and healthy, obviously uncontrolled diabetes right now, but the A1C goal is 7. Fasting goal of 80 to 130, postprandial less than 180. Justification or rationale. So basically we're kind of presented with what is the most appropriate move for this patient based on kind of some limited information we have. Something I think I may have noted at the top, but it's fine. This patient also is Spanish speaking and requires an interpreter via phone interpretation. So it seems that in the visit, and this is something that was hard for me to kind of write in this case, there's a lot of repeating of questions. And I can't always tell if that's through the interpretation process or through patients' low health literacy. So there's a lot of asking the same question of fairly, a lot of different ways to get a response that seems like the patient understood the question. So in terms of potential options, the patient's blood glucose in clinic is still elevated, no signs of hypoglycemia. Based on the most recent A1C, it makes sense. It's only been a couple weeks since the last A1C at 12.4, so likely still needs additional therapy. We're maxed out on metformin, Jardiance, and we're kind of reaching that point with our basal insulin where you start looking to other directions. So in terms of what we could do, we could add mealtime insulin, Humalog to the largest meal of the day, added DPP4, such as Januvia, that can help a little bit with some postprandial blood sugar. What was my other thought? We technically could increase Atlantis a little more if we thought that would kind of get us to our goal, or we could consider starting a once weekly GLP-1. And that's because the patient, his BMI was, it's over 40. And one of his issues was having, really overeating at night. He works really hard all day long and then just has this monstrous meal at night. So we kind of discussed the options and decided to start Trulicity 0.75 milligrams sub-Q once weekly. The reasoning, it could absolutely help get that blood sugar down quite significantly. And then it can also help with the appetite suppression while providing additional benefits with renal and cardiovascular. Okay, and do you mind going down a little bit more? So basically we're gonna maintain all the same medications. Those are fully written in the documentation. And then we're gonna start Trulicity sub-Q once weekly, follow-up call in 2 weeks, mainly to make sure the patient was able to pick up the medication with no issues, especially with the interpretation. Not sure what his pharmacy interpretive services look like. And then also see how he's tolerating it, if we need to, kind of readdress any of those educational points again. And then follow-up appointment in clinic in 4 weeks after kind of the first 4 doses are done to see if we need to increase the Trulicity at that point. So monitoring, the patient said that he was willing to monitor at least 2 to 3 mornings a week, which was a huge improvement just so we could see a pattern of his blood glucose improving, and then get the A1C 3 months from the last one. All right. Medical billing. So this is where things get interesting. So very, very happy to discuss this. For this one, problem type, what difficulties? I don't know what's happening on the other side of this claim. So maybe that is a difficulty in itself. And that's something we've talked about a few times in our meetings. So I put other for that reason. Service type, I said chronic disease management. Location, it took place in the office in our outpatient clinic. Code type, I don't know. I think it's evaluation and management, but I also wasn't sure if it was chronic care management. So I put, I don't know for that reason. Happy to talk about that. And then the patient had Medicaid. Patient type, like I said, it was a new patient to me, but it was already established with a provider, which patients in order to see us have to be established. So that will always be our answer for that. Number and complexity of problems addressed at visit. I said moderate, kind of, and I'm using a chart. I know everybody kind of has different resources. I'm using a chart that was provided by our clinic and hospital system. And so I ended up saying moderate for that. In terms of data addressed at visit, I did say minor. And I think my reasoning there was I wasn't looking at any external notes. I did review previous provider notes from our facility and previous labs, but I didn't think it was necessarily moderate. And the risk of complications, I did say moderate, and that was pretty much based on the, I believe just the prescription drug management part of it. All right, so I did say based on that, because 2 fell into the moderate category, a 99214 code for the established patient. Length of appointment was 60 minutes, probably total length was 80 minutes, including documenting. A big reason for that was kind of how I mentioned the interpretation that requires quite a bit more time because you're having to also wait for the interpreter, and then we kind of posed questions in multiple different formats that day. So ICD-10, I think it was E11.8. I didn't write that in there. So that was my case. Very happy for any feedback, thoughts. The interpreter component always throws me off a little bit when I'm deciding on the complexity. I feel like I've heard some mixed messages, so definitely happy to talk about that.
Okay,
I'm
Perfect.
gonna stop sharing, but I'm gonna send everyone in the meeting an email with this document. Is that okay?
Yes, that would be perfect. And then what we'll have is, I know we talked about me sharing it, but oh, perfect. The E&M code cheat sheet and the charts that A to Z uses. I know that, oh, there we go. Tom just forwarded those. So let me pull those up and I'll share that right on the screen.
It's shared, Renee. So we're
Well,
ready.
that's the very detailed one. So I thought you wanted the one that you just sent me, or you got that up.
That is the
Okay,
one.
perfect.
Yeah.
All right, so perfect. So Andrew and Zach, if you'd want to kind of quickly go through some of the specifics of how you would code that case, that would be perfect. Any
Yeah.
changes or things?
I think before we dive into that, my question, I want to turn that question back very quickly. I see the code you selected was the 99214. And are you selecting that code based off of the medical decision making or time?
Medical decision making.
Okay. All right. So Andy, do you want me to jump in, or?
Sure, go for it.
Yeah, I will. So I'll start off, and since you chose to code based off of medical decision making, I'll start with saying I do concur with the 99214 based off of medical decision making on the case that you presented. So the first thing to call out, whether this is a 9920, so a new patient, or a 9921, you kind of hit it exactly. This is a patient who was referred to you in your practice by a medical provider in the practice for collaborative drug therapy management. So when we are seeing someone in the same specialty, and when we're working under a protocol with another provider, we're considered working in the same specialty because they are essentially supervising or delegating that authority. That is correct. This is going to be an established patient. Now, if this were a different example where maybe you were a retail community-based pharmacist who has a independent authority in your state, and you were referred a patient to see, that might be an example where this could be a new patient. But in this case, you're correct. This should be a 9921 for an established patient. And then looking at your problems here, you're primarily managing diabetes. The patient does have comorbidities, but you talked just about the management of diabetes itself and the glycemia associated with it. So this is, as far as problems go, we have one chronic illness, so diabetes, and an A1C of 12.4, which is certainly not at anyone's patient-specific goal for them. So they are defined by AMA as being in exacerbation. Even if their last A1C was 13 and they improving, 12.4 is above their goal. So it's a chronic disease in exacerbation. Now, to hit a level of moderate, we have to have 2 or more of our 3 categories at that moderate level or exceeding it. And the other area where we meet moderate risk would be in the risk. And that's because in this case, we have prescription drug management. You have added a new prescription, so the long-acting, the weekly GLP-1 injection, and you're continuing 3 additional oral agents for diabetes. So in that regard, you hit moderate with the prescription drug management. Now, I want to call out that you brought up 2 points of complexity in this patient as well that actually raised the risk. And if there hadn't been prescription drug management, you still might be able to argue that this would be a 4. And that's based on the social determinants of health of the patient, namely that they have had non-adherence in the past due to financial stressors and changes in insurance, and they have a language barrier, and there's some question as to their health literacy. So all of those factors put together are social determinants of health that limit this patient's options for treatment. So that, if documented appropriately, could be independently of the prescription drug management enough to put the patient's risk at moderate. And that's that last bullet. Yeah, exactly. Now, the one area where I disagree with what you noted on your form is I would actually say that there is no data reviewed in the data elements. And the reason being is when we're talking about the review of data points, whether it is labs or charts or historical records of a patient, they have to be outside records or labs that were not billed by your organization. So it may meet the definition of minimal if that A1C had not been billed or used in the medical decision making of another provider, but in all likelihood, that was either a point of care lab test or the ordering and interpretation of that lab was used in the medical decision making of the previous provider at your practice. So though you did review it, certainly it's not something you can count as a data point because that would be double dipping. And in this case, the data isn't really going to change your level of decision making, so that point doesn't necessarily matter. We've hit moderate with the presenting problem and then the risk of your treatment options and the social determinants of the patient. And maybe, Andy, do you want to talk about the alternative option of time-based billing here?
Yeah, so from someone who's going to be auditing and reviewing your chart notes to see if this code's appropriate, which is a lot of what I do, this would seem, based on your time, you spend a lot of time on this patient. So if I was looking at this patient and based on your chart notes, did you note time in your chart note spent, or did you just keep that out?
I did not for this patient.
Okay, good. So when you note time, total time spent with the patient, that is a cue for anybody who's going to be reviewing this chart note to determine whether the appropriate level of service was chosen is if there's time. Did they note time either somewhere on top or within the note or on the bottom of the note? Doesn't really matter where it is, but there's a notation of the total time spent. That tells me that you are billing based off time, and that's how I'm going to review it moving forward. So that's an important practice point to keep in mind. Don't do both, choose one or the other, and just stick to a process that works. From a time perspective, you spent over 80 minutes with the patient, pre-work and on that day. Was that the total time you spent that day with the patient was 80 minutes?
I mean, I probably spent the 20 minutes the day before, like pre-charting and getting the note set. Yeah.
Yeah, so it's all about the total time you spent on the day of the encounter with the patient that you want to be adding to determine the level of service. The stuff that's done previously, you wouldn't want to calculate that in there. So if you lowered that down 20 minutes, you'd still, I think, would be at 60 minutes according to what you thought. So you're well within the 99215 category based off time. The tricky part with time, and exactly what Zach was talking about with the social determinants of health, is what I'm going to harp on. Time-based coding at 99215 should happen very infrequently in practice. It's appropriate when it's appropriate. And when is it appropriate in general is in the situation that you're describing to me right now. This is a patient that's new to you. You haven't met this patient before. You haven't managed this patient before. So you're going to have to take a more thorough history than you would for a follow-up. They're complex. You're probably doing a lot of education. Or reaffirming their knowledge base on how to use insulin, how to track their sugars. You needed a new blood glucose monitor in there. You probably needed to educate on that. All those are going to be good points of documentation that you're going to want to call out and signify within your note. The interpreter side of it for time is very useful because that time is medically necessary in order for you to be able to communicate effectively the expectations to the patient and what's going on. So the time with the interpreter, being a social determinant of health that could qualify for honestly, for me, pushes you easily into a 5 for justification if you chose to build this encounter based off time alone. I wouldn't push it to a prolonged service. That would be a hard sell for most plans, just because you're only managing one complex disease that's not at goal. And I'll reiterate that what Zach said. The real thing when we look at whether this is going to be a 99213 or a 99214 is this patient at goal or not? If they're not at goal, and that could be patient-specific goal, that could be a guideline-based goal, they're not at goal. And if they're not at goal, they're not stable. So they're going to automatically fall into a 994 category by default when you look at the number of diagnoses and complexity that you're treating. From a risk standpoint, as long as you've met the definition of prescription drug management, which is what a lot of providers struggle with. So if you just say continuing metformin, we argue at the health plan level and from the auditing standpoint, that doesn't meet this prescription drug management. We want to see some type of dialogue in there where you've assessed the appropriateness to continue metformin, discontinue metformin, and attach that to their current disease control. Being an A1C at 12, obviously we're going to be continuing metformin and Jardiance and probably everything else. But just having a one-liner in there goes a long way when people are reviewing your charts, because that gets you to that prescription drug management nearly immediately. By intensifying the GLP-1, adding it, you're meeting that right there because you discussed the options with the patient, and this is the preference that they really wanted to do. They didn't want to do more insulin. We had weight problems in there. Calling that out in your notes really important because it's substantiating the medical necessity of intensifying and also establishing that this is better than increasing more insulin or moving to more of a mealtime type of coverage. Those are really good points when you're documenting to really kind of hone this in. This is a 4 all day long, people, but given the interpreter, I'm choosing to bill it based off time because it's going to take a lot more time to discuss this with the patient, and it's medically necessary time. So you could probably go for a 4 on medical decision-making or a 5 with this particular patient.
Yeah, a 5 based off of time.
Yeah.
Yep.
So I know that was a lot of information, and I know we're a little bit over on time, but I wanted to make sure to kind of state 2 points. One is that we're going to continually come back to these. So these are going to be continually examples that we're going to grow and develop. And we're going to post all of this on the setup.com website so that you'll have access to this as well and access to kind of putting additional questions. But I also wanted to open it up in the last maybe couple minutes. Are there any burning questions that that any of our sites have kind of based on this case or based on examples of what they've done that maybe needs a small clarification? Okay, so I don't hear any questions, but what I'd like to bring up is that on the website, there is a space where we could actually have you ask the experts. And so we can have you put in additional questions as you're thinking about it. And think about your case of your diabetic patient who might be struggling, who's similar to our 54-year-old, and any questions that you have regarding how this patient's kind of interaction was coded, and maybe clarification. And then we can bring those up at the next meeting. And in the future, we'll have this down a little bit smoother. So thanks for our growing pains. And so kind of making sure that we have our topic presentation and our case presentation and make sure we have a little bit more time. So we're going to tweak a few things. We're going to have a debrief and make sure kind of what went well, what could be better, and kind of other opportunities. And so you'll see, and on the website, there's the upcoming topic presentation and case presentations.
And I'm displaying that now.
Mm-hmm.
And if you see your name, I've talked to most of you, but if you see your name next to this on the case presentation, and maybe we'll wrap up with this. The way to submit that case is you go to the home page here and you hit this button here. I want to submit case. You type in your name and email, and you'll get an email from this website where it'll go to a Qualtrics page where you just type it in. Remember that these are cases that are to really specifically to talk about billing. And so you can be brief in your patient case presentation, like Jordan was today. You don't need, it is not a classic patient case presentation, rather enough information to get us to where we can discuss the billing part of that. We're going to try and get a variety of cases so that everybody here, depending on your practice site, will find interest in what we're looking at. So we'll be looking at immunization cases and lab or point of care test cases, doing injectables at a community pharmacy. How does that look when it comes to billing? So all those things are coming up. So if you didn't see yourself in today's case, there will be places in the schedule where you should see yourself, and it should be super useful to you.
We will work to get cases to everybody as much ahead of time as possible, so that if you wanted to write your own notes next to the cases, that might be a little bit more beneficial depending on how people think. So without any further questions, we will end this session. So thank you so much for being at the inaugural first version of our training. And we will post that on the website. And then if you have any other questions, again, post them onto our setemup.com website.
Thanks,
Thank you,
everybody.
Andrew. Thanks, Zach.
Andrew and Zach, awesome.
Thanks, Jordan. And thanks our visitors in Jordan's office.
Yeah, students. Yeah, thank you, Zach and Andrew. I appreciate that feedback. That was cool.
Absolutely. Thanks for presenting today.